So, good evening, everybody. On behalf of IMA KSP and Women Doctors Wing, welcome all of you for today's interesting webinar. I'm sure, especially those who are from pediatrics and obstetrics, especially, are well aware of this problem and the risk involved with both.
Not audible.
Yeah, sir, we lost the voice, audio.
Can you hear me?
Yes, sir, we can hear now.
Yeah. So, as a Secretary of the State Branch, I take this opportunity to welcome you all with IMA prayer. So, start with the prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ, ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, ಐಎಂಎ ಚಿರಯುವಾಗಲಿ. Dr. Bhargav, it's over to you. Thank you so much.
Thank you so much, sir. Thank you. I'll start the program with a welcome to our Honorable President, IMA KSP, Dr. Shivkumar Lokal, sir, our President-elect, Dr. Srinivas, sir, Dr. Karunakar, sir, who's been kind enough to start the program with the IMA prayer. Dr. Lokal, sir, I request you to please say a few words for this webinar. And then
can you hear me, madam?
Yes, sir.
Good evening to all. Indian Medical Association Karnataka State Branch, Women Doctors Wing, in association with both the organization webinar series Rising Stars. This is a very good, appropriate word kept by the Manpreet Kaur Madam, Rising Stars. Today's topic is insulin in gestational diabetes meditation. Really a very good topic. Today we have our Secretary Karunakaran and Treasurer Dr. Vijay Sarathi and Chairperson Dr. Manpreet Kaur. And we have got a very good speaker, Dr. Sandeep. He is basically from Hubli. I know him very well. I think he can remember me. Sandeep sir, can you remember me? I had so many interaction with you, and a very good endocrinologist and also diabetologist. We are fortunate to have him. Today's topic, that is insulin in gestational diabetes medicine, and we are very fortunate to have a chairperson like Dr. Sushila Rani Madam, consulting endocrinologist, Manjusri Specialty Hospital, Bangalore. So really we are fortunate, madam. We welcome you all for this webinar. We want to hear your inputs regarding that. So without taking much time, I hand over the mic to Chairperson Manpreet Kaur. Thank you, one and all. All the best.
Thank you so much, sir, for those kind words. Now, before starting the scientific session, it is my honor and my privilege to introduce the chairperson of the talk, that is Dr. Sushila Rani ma'am. Ma'am is, as sir has already introduced, she is the consultant Manjushri Hospital in Bangalore, a gynecologist par excellence and an avid academician. I've had the honor of sharing scientific space with her on a few occasions. And every time, believe me, I have come away thoroughly impressed and inspired by her knowledge and her joy de vivre, and also her passion for this obstetrician and gynec profession that we are in. So when we from WDW requested her to chair a session on insulins and GDM, knowing how passionate she's about this particular topic, ma'am agreed despite her extremely busy schedule with patient care commitments. And we were extremely excited that we were going to have an excellent and impressive speaker and a chairperson who is going to give a lot of inputs to this, because this is, I think, her pet subject: insulins, GDM, and how to save the mother and the baby, and see to it that they have an uneventful and uncomplicated journey through those 9 months of pregnancy. I welcome you, ma'am, and over to you, ma'am.
Thank you, Manpreet. Thank you for inviting me to chair this session. And I also thank the IMA Society President and the Secretary and the entire team of IMA for having me chair this session, or considering me good enough to chair this session. Thank you so much. When it comes to insulins, I suppose, the moment you say insulin to a pregnant woman, she gets kind of a shock. Because pregnancy is something that you really look forward to, and then you think, the path is full of roses, and then suddenly you say your sugars are high, and then you need insulin. There is a kind of non-acceptance because of certain considerations that are there as far as insulin is concerned. One thing is that they think once you take insulin, you will have to take it throughout your life. So, my God, can I avoid this insulin at any cost? Second is that, my in-laws don't know. They will label me as diabetic. What if I have to take insulin? Then, I'll become a social outcast. This also is a consideration. And nobody knows to give insulin in my house. How will I manage to take insulin? I have to ask somebody to come and give the injection every day. These are some of the considerations when it comes to insulin. So making it simpler, easier for them to understand is our job as obstetricians and physicians and endocrinologists, and making them aware that insulin is a drug of choice when it comes to hypoglycemia and pregnancy. Of course, MNT, that is diet and nutrition, plays a major role, but insulin is the drug of choice. It's a standard of treatment in cases of gestational diabetes. And because it is so safe for the mother, it is safe for the baby, and it's the whole lot of advantages, which I'm sure Dr. Sandeep will say. I don't want to go through all those things. So over to you, Dr. Sandeep. Please enlighten us about insulins and GDM. Yes, Dr. Sandeep is Namma Mane Hudga from, he passed out MBBS from Hubli, KMC Hubli, and MD from Belagavi. He did his DM in endocrinology from our own medical college here in Bangalore, MS Ramaiah, and specialty certification. What is it? Certification examination. He passed it out in endocrinology. This comes after MRCP, and that's indeed a huge credit to his academic career. Of course, he has done a lot of research, which includes factor 8C and macrovascular complications of diabetes, everything related to diabetes, and some 1 or 2 things related to thyroid, association between glycemic gap and adverse outcomes in critically ill patients with diabetes, correlation between ultrasound, FNAC, and histopathology of thyroid nodules, glycemic management in patients undergoing cardiac transplantation with diabetes. This must be a huge area of interest, because there are several papers of his related to cardiac cases and glycemic management, and he was a sub-investigator in dual factor 8 clinical research drug trial, and he has several publications to his credit, like I said, about association between glycemic gap and adverse outcomes in critically ill patients with diabetes, and perioperative glycemic management of patients with type 2 diabetes mellitus undergoing cardiac transplantation, and perioperative glycemic control in patients who underwent cardiac transplantation, and the effect on the outcome at discharge in a tertiary care center. So these are some of his publications. I'm sure he's a young, smart, very academic-oriented endocrinologist who is going to enlighten us about insulins in the management of gestational diabetes mellitus. Over to you, Dr. Sandeep.
Thank you, ma'am. Before begin my presentation, first of all, I'd like to thank the organizers, Indian Medical Association, Karnataka State Branch, Women's Doctor Wing. I would also like to thank Dr. Shivkumar Lakkod sir, Dr. Karunakar sir, Dr. Vijay Sathi sir, and first of all, Dr. Manpreet Kaur ma'am. First of all, considering me and giving me this wonderful opportunity to talk about this topic, which is a day-to-day thing for us. And the icing on the cake is that the session is being chaired by Dr. Sushila Rani ma'am, whom I have met earlier and heard her talk about specifically gestational diabetes. It is a privilege, ma'am. Without wasting much of our time, I'd like to begin my presentation. So we know that the burden of gestational diabetes, not only gestational diabetes, but also diabetes in general and the whole gamut of lifestyle related disorders is on the rise in our country. And not only this, our country is also going to have the largest largest population in the whole world. So with this, it brings a lot of challenges which are going to arise. We may not be the country with the most populous people with diabetes, but if the trend continues, it might be that in a few years, we might be the country with the most populous diabetic population. So coming to gestational diabetes, the rates are estimated to be 3.8% to 21%, which is much higher than the worst. It is, we don't have a pan-India study, we have a lot of smaller studies. That's why the wide range in the rates of gestational diabetes mentioned here. So Asians are higher risk compared to Western population with regards to gestational diabetes. In 2010 itself, we had around 22 million diabetes mellitus patients aged from 20 to 39 years. So 54 million women with impaired glucose tolerance or pre-diabetes with potential to develop gestational diabetes. So having this background, the topic for my today's presentation is insulin for the treatment of women with gestational diabetes. So basically what I'm going to discuss today is to understand the importance. We all know the importance of maintaining glycemia in pregnancy, the impact it has not only on the mother, her whole experience of pregnancy, but also on the well-being of the fetus and the child who is going to be born, and not only just after pregnancy, after delivery, but also throughout his life, the impact it has. We will also be trying to identify the different types of insulin and the recommended use in pregnancy. We'll be learning about the management of gestational diabetes with insulin therapy and to recognize the potential risks associated with insulin use in pregnancy. We all know the definition. Diabetes diagnosed in the second or third trimester of pregnancy simply that was not clearly over diabetes prior to gestation is defined as gestational diabetes. Different definitions are there. Prevalence, as we know, is gradually increasing along with the prevalence of other lifestyle-related risk factors like diabetes, obesity, and dyslipidemia. The recent estimates put for gestational diabetes are up to 15% of pregnant women worldwide. It is important to identify the risk factors. Why? Because it is very essential to know this during our pre-conceptional counseling, where we know as ethnicity being Indians, we have already one additional risk factor. But when the risk factors pile up, it is also a teachable moment in the pre-conceptional counseling, or the girls who have come to us with other problems like polycystic ovarian disease, where it is a teachable moment, and we can impress upon that with the lifestyle related changes, they can reduce the incidence of their chances of having gestational diabetes during pregnancy. So why does gestational diabetes occur? So basically, pregnancy is a state of insulin resistance. The thing which it occurs because is that there is a physiological changes occurring in the mother throughout the pregnancy. One thing which occurs is that there is an increased mass of beta cells. As with any endocrine organ, there is increase in the cell mass with regards to pancreatic beta cells also. But along with that, there is an increase in adiposity also. And placenta comes into the picture, whereby it secretes certain hormones like human placental lactogen and others. Paternal adiposity increasing brings to its related factors like increase in the free fatty acids. And we know that increase in the free fatty acid level is directly linked to increasing insulin resistance. So that adds to the factors which are already present. So relatively, even if there is an increase in the beta cell mass, because of the other factors which are increasing the insulin resistance level, there is overall the risk of gestational diabetes increases. So the glucose levels are increasing, but why should we worry about these increased glucose levels? So the impact of increased glucose levels, as we can see, is not only on the mother on the delivery, but also on the baby, as we can see the complications here. So this slide I have highlighted, it demonstrates the comparison between preterm delivery rate and the HbA1c in the third trimester. As you can see, the higher the level of HbA1c, the higher the risk of preterm delivery. So this result has been seen from the time of earlier studies like HAPO study, where they saw that there is a continuum of relation between the HbA1c levels or glycemic levels and the risk factors like preterm delivery. So you want the HbA1c level to be as low as possible. We'll look at what are the levels in the further presentation. Now that we know that what is how to define gestational diabetes and what is the importance of identifying the risk factors. Now we come to the diagnosis. We have a lady who has come with the risk of gestational diabetes. So those who have risk factors, these are the NICE guidelines. We'll come to the India specific guidelines also. We use a 2-hour 75-gram OGTT for gestational diabetes with women with risk factors. Those who had gestational diabetes in previous pregnancy, it is always better to do early self-monitoring of blood glucose or a 75-gram OGTT as soon as possible after booking, and then a further OGTT at 24 to 28 weeks. So the IID PSG criteria is what is recommended by the American Diabetes Association. So it is there are two strategies here. One is a one-step strategy and other one is a two-step strategy. The one-step strategy, we do testing at 24 to 28 weeks of gestation, and we give a 75-gram glucose in on the fasting state. We do a fasting glucose level and a 1-hour glucose level and a 2-hour glucose level. If any the fasting glucose level cutoff is 92 milligram per deciliter, 1 hour is 180 and 2 hour is 153 milligram per deciliter. So the criteria here is that if any one of the values is exceeded, then you diagnose the woman with gestational diabetes. This is the most commonly used by test by endocrinologists. Then there is a second two-step strategy where you do a 1 hour post glucose level after giving a 50 gram of glucose. If the level is more than or equal to 140 milligram per deciliter, then you go with a two-step strategy where you do a fasting value, give 100 gram glucose load, do a 4 values. And if any of the 2 values are above the cutoffs, that is 95, 180, 155, and 40, then you go ahead with the diagnosis of gestational diabetes. The India-specific thing is that we have a large population, and due to the time constraint and the time constraint and other problems related to women coming for on fasting glucose levels. So that poses a problem in diagnosis. So that's why to cover a larger population, we have something called as the 75-gram glucose challenge test. It is irrespective of the previous meal, can be done anytime. So single post glucose load at 2 hours, more than or equal to 140 milligram to diagnose the woman with gestational diabetes. So here the first test is in the first trimester, ideally 12 to 16 weeks. Then the second test, if negative, done at 24 to 28 weeks. And the third test in the third trimester, ideally in the 30 to 34 weeks period. So economical, simple in the Indian setting. Now that we have diagnosed the woman with gestational diabetes, we have to look at the treatment approach. As Madam already told in the her introduction regarding what is the best treatment for gestational diabetes, and that is insulin. We'll discuss a little bit about how to approach the treatment. So this is a study from 2020, which saw that after the advent of introduction of lifestyle changes, that is the diet and physical activity, in women who were diagnosed with gestational diabetes, majority of them had adequate glucose control, that is 70 to 85%, and they were advised to continue on diet modifications and physical activity. Then again, they have to be, if diagnosed in the first trimester, repeat the diagnostic challenge again in the second or the third trimester. So 15 to 30% of the women who had inadequate glucose control, even after the lifestyle and diet changes, then they looked at what the treatment was given. Primary option here was insulin. So the options which are available, which were used in these women were the long-acting glargine and detamers, short intermediate acting regular NPH, rapid-acting aspart, and lispro. So secondary options which were used were metformin and glibenclamide. So what does NICE recommend? So you have a woman with who has been diagnosed with gestational diabetes. Now, what do we, which treatment do we choose? So NICE recommends that when there is a trial of diet and exercise, and fasting plasma glucose is less than 100 milligram per deciliter, offer metformin as a first thing, then observe the glucose levels for some time, 1 to 2 weeks approximately. If the glucose levels are not being controlled, then you can think of adding insulin. If the fasting plasma glucose level is more than 126 milligram per deciliter or above, then you have to go ahead with the introduction of insulin as a first-line agent with or without metformin. So insulin can also be considered with immediate effect in women who have a fasting plasma glucose from 110 to 126, and additional risk factors like macrosomia or hydramnios. So they recommend that to consider glibenclamide for women who have blood glucose targets which are not achieved with metformin, but those who decline insulin therapy. So this is a very common occurrence, as Madam already mentioned. There is a lot of stigma associated with insulin. First of all, the awareness regarding insulin is very, very low. And along with that, there is the stigma associated with insulin is very high. But what we have seen in our clinical practice is that once they know the importance of controlling the glycemic levels and the ease of insulin usage in the current scenario with the availability of newer devices, newer insulins. So the acceptability goes up very high. So when do you think of admitting a woman with gestational diabetes? When the blood glucose levels are very high, there is fetal distress, there is ketoacidosis. The other thing also is important to remember is that the incidence of euglycemic ketoacidosis is higher in pregnancy. That also has to be considered. Other things like preterm labor, other medical complications like preeclampsia are also they call for need for admission. Now that we know how to diagnose and which to initiate, what method of treatment to initiate, and when you have decided that we are using insulin, what is the dosage to use? Before going on to the dosage, let us have a slight look at the physiology of glucose in our body. So this graph depicts on the the y-axis we have insulin secretion, and on the x-axis is the timing. So timing, as you can see, it is depicting different meal intakes. So after the intake, what happens in our body is that the carbohydrates getting digested, go into the bloodstream in the portal vein specifically, and in the portal circulation, and they reach the pancreas beta cells. Once the glucose reaches the beta cells, there is a rapid release of insulin which is present in the pre-stored granules, pre-stored in the granules in the beta cells. So there is a rapid spike which we can see here. Yeah. So rapid spike, that is the first phase of insulin, and this glucose also stimulates the insulin synthesis, new insulin synthesis, which leads to the second phase of insulin secretion. So all we have to know is that when there is a food intake, there is the insulin spike. So this insulin secretion, which occurs with the food intake, is short-lived. It is meal-related insulin peaks. This we call as bolus insulins, meal-related insulin release. Apart from this, there is also some amount of insulin release which is occurring long after the food intake also. So this we call it as the basal insulin secretion. So the importance of basal insulin secretion is that this insulin secretion checks the hepatic glucose output. So even at rest, when we are not taking food, because the body needs glucose for its activities, specifically important organs like brain, others, there is some amount of glucose release which is happening from the stored glucose in the liver and kidney in the form of glycogen. So glycogenolysis and the neogluconeogenesis ensures that there is a glucose supply at the rest phase also. So whenever there is insulin resistance, insulin is not able to check how much of glucose output is happening from the liver and kidney. So this leads to increased efflux of glucose from the liver. That leads to higher levels of glucose in the blood in the resting state. So this mostly is seen when you do a fasting glucose level. Fasting glucose level is higher. So when we look at logically at this, when we want to mimic this physiological insulin secretion, so we know that there is one insulin which is secreted when we take food, and there is one insulin which is taking care of the basal insulin secretion, which is checking the glucose output from the liver. So approach vastly depends on the presentation of the woman. For postprandial hypoglycemia, approximately if she is taking carbohydrates, for 10 gram of carbohydrates, 1 unit of regular insulin is required. Approximately comes to around 4 to 6 units, which is to be taken before the meals. If there is fasting hyperglycemia, we have to look at some basal insulin or intermediate acting insulin, which is widely used, that is NPH. That is 0.2 units per kg per day, or approximately 10 units at bedtime. So this is only a guideline. It all depends on how much the fasting plasma glucose level is, and depending on that, you can vary the dosage of NPH or the intermediate acting insulin which you are using at bedtime. So the titration is adjust the doses approximately by 10% until the glycemic goal is achieved. Anticipated dose is 0.7 to 2 units per kg per day. This is mainly derived from the Western literature. As we see in the Indian scenario, the final dosage is on the lower side, approximately around 0.6, 0.7, 0.8 units per kg per day. A simpler approach will be to add prandial insulin, that is a meal-based insulin, starting dose around 4 to 6 units. And if the fasting plasma glucose level is more than 120 milligram per deciliter, use a basal or intermediate acting insulin. NPH is the most common one. Even now we use the dosage as we know already. So in those patients where basal bolus regimen, as we call it, is not convenient for the patient, premix regimen can be considered. But we have to understand the limitations of the premix regimen, which I will talk about later. So the importance of this slide is it depicts the mean daily insulin requirement throughout the pregnancy. So this is so what it depicts is that once a woman conceives, as a lady conceives, we see the a little bit increase in the insulin requirement. But in the first trimester, week 10, week 11, we see a drop in the insulin requirement. So this is where we have to be cautious. If you are a lady with pre-gestational diabetes or type 1 diabetes with who has conceived, the insulin requirement might go down. This is also the time when there is a lot of hyperemesis. So because of the reduced food intake and also because the insulin requirement is going down, the chances of hypoglycemia here increases. And as you can see, we go to the second trimester, the insulin requirement goes on. And in the third trimester, you can see the insulin requirement goes as high as to the increment of 70% from the baseline insulin requirement. So these scenarios are very common in the clinical practice. So here what happens is that the insulin you have diagnosed the lady with gestational diabetes in the second trimester. You started her on good doses of insulin, and she goes on to the third trimester, and she has been having very good glycemic control with the doses. But suddenly the sugars start spiking up, and she starts requiring more amount of insulin. This is when patients panic because the requirement is going so high. So this we have to consider whenever we are dealing with the woman with gestational diabetes. So now we come to the insulin options, which we have to consider. So this is a whole list of insulins which are available. The initial ones from insulin, regular insulin, fast-acting insulin, aspart, insulin, regular insulin, aspart, lispro, glulysin are the rapid-acting bolus insulins. Later insulins like detemeric, degdudec, glargine, NPH are basal insulins. And then there are pre-mixed insulins, which are available in the combination of 30%, 30-70, that is 30% short acting and 70% intermediate acting, or also present in the form of 50-50, that is 50% short acting and 50% intermediate acting. So the pregnancy FDA category for insulin glulicin is category C, so we mostly don't use it. The Indian guidelines also say that there is not much data, so we end up not using glulicin. Insulin degludec and glargine are in the category C. So glargine, if already being used in a woman who is type 2 diabetes or type 1 diabetes from before pregnancy, and she has excellent glycemic control, it is logical to continue using glargine and have good glycemic control. It will be an added advantage. With regarding to degludec, there has been a recent study where they looked at comparison of degludec with detemir, and they found that degludec did not have any adverse effects compared to detemir. Detemir has, as we know, category B for treatment of hyperglycemia in pregnancy. So if this comes into usage, it will be a very good addition because it has very long basal duration of action. In many of the cases where large amounts of insulins are used and still the hyperglycemia, like fasting plasma glucose, is not controlled. So in those cases, it becomes very important. Since these basal insulins, the truly basal insulins, the newer generation basal insulins, have a flatter glycemic profile compared to, let's say, NPH, which has a peak and a shorter duration of action compared to these. The incidence hypoglycemia also, that specifically nighttime or early morning hypoglycemia also is reduced with these newer generation basal insulins. So, with regard to mimicking the insulin secretion which happens in our body, are we there yet? So this is how the insulin secretion happens. That is a rapid spike immediately after food intake. But this is how the insulins, that is the regular insulin, is acting. As you can see, it has a later onset of action. So it misses the postprandial glucose surge, and that's why it is not able to meet exactly the postprandial insulin requirements. And if you see in the post-absorptive phase, later after 2 to 3 hours after the meal, where the insulin action should have ended or come to the baseline, it is still acting, leading to the late post-meal hypoglycemia, or let's say pre-meal hypoglycemias like before lunch and before dinner. With regards to the basal insulin, as we know, the basal insulin secretion is always flat, but the insulins which we most commonly use, that is NPH, does not have a flat profile. As it doesn't have a flat profile and has a peak, it leads to higher incidence of hypoglycemic events. So the problem with pre-mixed insulin, which is most commonly used in clinical practice, is that it has the defects of both these insulins, that is later onset of action, and also it doesn't have a flat basal profile. So lot of hypoglycemias happening. What we generally see is that if the insulin requirement in the lady diagnosed with gestational diabetes is not high, pre-mixed insulin like the pre-mixed 30-70 or 50-50 do suffice, and there is not much other newer insulins required. But when the insulin requirement increases, Then the problems of hypoglycemia and not meeting the glycemic targets postprandial comes into the picture. That's when it is always better to go with the basal bolus regimen. So this is depicting the shift from modern insulins. We need better insulins which are ultra fast acting. They have a steep surge and a rapid decline of action. And basals, we still need newer basal insulins which have a flatter basal profile. And we should, very important that even though premixed insulin is most commonly used, we have to know the limitations of using premixed mixed insulins in pregnancy. Let us look at the evidence of regarding different insulins a little bit. So these are some studies, the global studies. The overview is that when they compared the aspart along with regular insulin, whether used in combination with NPH or alone, they saw that there was better postprandial glucose control with the newer insulins, but they had similar maternal and neonatal outcomes. Some studies from India also, in these studies, they saw that the insulin aspart or with or without NPH, glycemic control was good. It had a lesser incidence of macrosomia in both GDM and pre-GDM, but we have to look at the number of the population involved also. This is a smaller study. So we have to take it with a pinch of salt. So there are other studies also which have depicted that number of episodes of postprandial hypoglycemia was minimal and also minimal incidence of hypoglycemia. So as I already mentioned, insulin glulysin is classified as class C FDA. In Indian label guidance, there is no adequate data in pregnancy, so we don't use glulysin as a bolus insulin. There is newer, faster acting aspart, which is Fiasp, which is available. That also has been found to be safer in pregnancy. And when we look at the usage in clinical practice, barring the cost factor, with the convenience, if you look at it, and the glycemic targets, if you look at it, Fiasp and other insulin aspart fare very well compared to the regular insulin. So also available as a combination insulin, the aspart with premixed insulin. Now we come to the so this is how the profile looks like. The regular insulin onset of action, as we can see, is late, that is 30 to 60 minutes. Peak action is 2 to 3 hours, and effective duration is approximately 8 to 10 hours. So this is the effective duration. So analogs like Lispro and aspart act. The onset of action is approximately 5 to 15 minutes. Peak duration of action is 30 to 90 minutes, and effective duration is 4 to 6 hours. So even though not exactly as the physiological, but closer to the physiological insulin release compared to a regular insulin. So other advantages of using the newer analogs is that you do not need to wait for 30 minutes for the action to occur as with regular insulin. So many a times patients face this problem that they are not able to wait so long after taking insulin, and they end up taking the food earlier only, leading to they not meeting the targets or having hypoglycemic events. Let's look at some basal insulin which are available. So Detimir is the truly basal insulin which we are most commonly using. When we compare with NPH, they saw that Detimir was associated with longer term pregnancy, and it also showed a better fasting plasma glucose control. So whenever we are not able to meet the targets with NPH alone. We try to shift to detemir, though cost is a very important barrier in this scenario. So insulin detemir is the basal insulin classified as class B, safe in pregnancy. So there are other studies which have looked at the comparison between the newer and the older insulins. When we look at the basal insulins, as we can see, the duration of action of NPH is 14 to 24 hours. Varies a lot. When you compare in the same individual also, and in the individual to individual variation also. So the newer insulins like glargine, though we don't use it so commonly, detemir have longer duration of action, and now degludec, which probably will get approved for usage in pregnancy, has a very long duration of action. So the usage of newer insulins probably will have a better outcomes in pregnancy. So now that we know which all insulins to use, how to initiate, we'll go to the little bit practical aspects of insulin injection, storage, other things. So when we look at the storage, so insulin in products, all the insulin products should be stored at 2 to 8 degrees centigrade, preferably in the fridge door compartment, in the farthest away from the freezing compartment as much as possible. You should not store the insulin below 0 degrees. It may freeze, the vial may crack, and other complications. Whenever the patients are using insulin, active usage, so active usage, the temperature, effective temperature should be less than 25 to 30 degrees. And this insulin, which is an active usage, has to be consumed within 30 days. So that's what they have studied, that it remains bioactive up to 28 days. So during transportation, we have to maintain a temperature of 2 to 8 degrees because there is uncertainty regarding the variation of temperature, and also we have to ensure that there is no exposure to sunlight. So with regards to other factors, humidity, there is no special requirement. Light, we also should ensure that the insulin products are stored away from direct sunlight and strong artificial light. Wet conditions like rain, sleet have to be avoided. Other thing, very important practical aspect is that we should never store insulin or carry insulin along with dry ice. Whenever we are using pen device, we should always detach the needle part and keep it separately, because the insulin in the needle part can freeze, form bubbles, it may leak, and change the composition if it is a premixed insulin. So when looking at injection, using a vial, always make sure the sanitization, it is a sanitary procedure. Clean the top of the vial with the alcohol swab. Draw air equal to the amount of insulin which has to be injected. Push the needle through the vial with keeping the bottle upright, and then invert it and draw the insulin and pull the syringe out. Make sure that there are no bubbles. If there are bubbles, then reinsert the syringe in the bottle, and after injecting, draw again so that there are no bubbles. And make a skin fold using two fingers. Skin fold is usually required in thin individuals. In moderate, overweight or obese individuals, a skin fold thickening is not required. Always inject the syringe 90 degrees. After injecting, and the plunger has come to the 0 point, we have to wait for approximately 10 seconds, and then. So similarly, when using a pen device, make sure that there is the the expiry and type of insulin is accurate, and there is no bubble in the pen device. And make sure that whenever we are injecting, sufficient dose of insulin is present in the pen device. If there is a constitution difference, if you see white thing specifically with the premixed insulin, we see that there is separation between the short-acting component and the long-acting component. So what we can do is, rather than shaking and to avoid the formation of bubbles, we roll the pen device between the two hands, or rotate it vertically, and make sure that there is resuscitation of the two insulins. And always make sure that you prime, and priming is the process where you keep the pen erect and inject, press about the dosage of 2 to 3 units of insulin, and make sure that the insulin is coming out of the needle to ensure that the pen is working. And after that, dial the dose desired and repeat the steps again. Preferably, it is advisable from the manufacturer point of view that the needles which are used to be discarded after each time. But in the Indian scenario, it becomes a very costly affair. And according to the FIT recommendations, also the latest ones, it is okay to use reuse the needles approximately around 2 to 4 times. So, but it should be made sure that needle is not bent. There is no injury occurring with the needle. Whenever there is pain due to the needle, it means that the needle has become blunt. Many of the times, this thing is not explained to the patients, and they think that one needle is for one pen, and they use the same needle with the pen for sometimes weeks together. So this is an important part. The site of injection is around the umbilicus, or 3 to 4 fingers away from the umbilicus in the lateral aspect of the abdomen, anterior and lateral aspect of the mid thigh, and over the triceps, upper arms. Also can be injected in the upper or outer part of the gluteal region. So this is very important. Many times patients are afraid of the needles, and they think if they inject the needle, it might go inside or they might injure something. So when they do, what they do is that they inject the insulin with an angle. So as you can see, when you inject the needle at an angle, it ends up being in the surface layer, that is the epidermis, and insulin gets injected in the epidermis rather than the subcutaneous tissue. This might lead to ineffective delivery of insulin, also lead to injury or other things. So abdomen is the best site to inject because it is easier for the patient himself or a patient herself to take it. Other sites I have already mentioned. So we have other vials also, which are available in the 40 units and 100 units doses. So we should always make sure that it is matching with the insulin which is there. So insulins are available in most commonly the 40 IU insulins, that is 40 units per ml. And then there are 100 units per ml whenever we use it for individuals who require more than 40 units at a time. So whenever taking insulin, we have to make sure that there is adequate separation, and we use different sites, keep rotating it, thus to avoid the lipohypertrophy. So key message is that storage, we have to remember insulin in use has to be used within 28 days and up to 25 to 30 degrees to be temperature to be maintained. Now looking at the glycemic targets. So most targets most guidelines recommend a fasting plasma glucose or a pre-prandial glucose of less than 95 milligram per deciliter, a 1 hour postprandial glucose of less than 140, and a 2 hour postprandial glucose of less than 120. When we are using regular insulin, it becomes very hard to follow the 1 hour postprandial glucose level because the onset of action is a little bit late. So we end up using the postprandial glucose level whenever we are using the regular insulins. So these are the guidelines with regards to the targets of glycemia in pregnancy. It is best to have a HbA1c of less than 6% during pregnancy without having any hypoglycemia if you are not having any hypoglycemic events. If there is hypoglycemic events, then we have to go with the 6.5%, and at least less than 7% has to be maintained according to ADA. So newer devices are also available. We have continuous glucose monitoring, which is available more commonly now. This is more useful in women who have type 1 diabetes and have conceived. So they have to check the glucose levels approximately 6 times. So it becomes very cumbersome and painful because they will have so many other things to take care of also. So this becomes very useful. So there are certain studies which have looked at women who have with comparison of continuous glucose monitoring and those who did the finger stick glucose, and they saw some changes like approximate, for example, last for gestational age chances was higher with those who did the finger stick glucose compared to continuous glucose monitoring. And other things like neonatal hypoglycemia requiring dextrose, intravenous dextrose, was also higher with usage of the regular finger stick glucose compared to usage of continuous glucose monitoring. So these are newer studies, that is a concept trial. Probably as these technologies become more affordable, we'll be able to use it more widely. We are already using it in clinical practice whenever there are difficult cases where we are not able to gauge what is happening exactly to the glycemia. So these technologies give us a whole picture where they give us a picture of glycemic status of an individual for 24 hours. That helps us making decisions in the difficult case scenarios. So these are the targets for continuous glucose monitoring. So the thing I want to stress upon is the time in range. Time in range is 70 to 180 here, has to be more than 70% of the time. In pregnancy, the targets are 63 to 140, that is 70% of the time the glucose level has to be there in that range. So no insulin treatment, we always have to remember the risk of hypoglycemia. Though the risk of hypoglycemia is lesser in gestational diabetes compared to women with type 1 and type 2 diabetes. First half of the pregnancy, insulin sensitivity is increased and women have nausea. That is when the risk of hypoglycemia is higher. As we already know that premixed insulin, higher doses when we are using it, the risk of hypoglycemia is higher. Other thing, pre-gestational diabetes, glycemic control is not so good, and there is rapid control of glycemic status that can induce retinopathy. So pre-gestational diabetes or type 1, type 2 diabetes, conceiving, always make sure that we have to check the retinopathy status in the first or the second trimester. Also pregnancy also predisposes to retinopathy. So how do we manage hypoglycemia? Whenever hypoglycemia is there, less than 70 milligram per deciliter is called as the glucose alert value. Usually in pregnancy, the glycemic status is on the lower side. So look at the symptoms of hypoglycemia, and if they are present or the glycemic levels are dropping, we have to give 15 to 20 gram of glucose. That is a preferred treatment. If not available, any form of carbohydrate like a juice box is also can be given. 15 minutes after the giving of carbohydrates, if you have to check again and hypoglycemia is present, then repeat the glucose load. Once the glucose levels are picking up, if it is a meal time, ask them to consume a meal or a snack to prevent recurrence of hypoglycemia. We are coming to the end of my presentation. I'll not take much time. So the sliding scale has been there from very long time. I would say it is like a dinosaur, but still it is living among us. So these are the things which have the wordings or the statements which have been used in various journals. The use of sliding scale could be considered as a medical myth, because medical myths are concepts which we are taught. They are wrong. Myths are usually easy to remember and thus are passed from generation to generation without evidence of support for their use. More than 50 years of several editorials and original articles have discouraged its use. So you can look at the heading of this 1963 editorial, which was titled, "Let's get the sliding scale out of medicine." So, but we still use it. The origin is from Elliot Johnson from 1934, when we didn't have glucose monitoring. We used to measure glucose only by seeing the color of the urine using the Felling test. So this is how insulin sliding scale looks like. 2, 4, 6, 3, 6 units according to the glycemic levels, and it's mainly a reactive approach. Why? Because it is convenient to use. That's why it is more commonly used. You don't need to call the doctor. You don't need to call the doctor after admitting the patient. How much to be given? What is the dosage? For the nursing staff also, it's very easy to follow. And you don't have to take a history. You can initiate it right away. But it is not evidence-based. It is a reactive approach. It creates something called as a roller coaster effect. It doesn't take into account the individual's specific history. So most important thing I would like to highlight here is that there is a glucose pattern to every individual, and the time of measuring of the insulin, the glucose value of the individual will tell you how much insulin you are going to give when using a sliding scale insulin. So suppose you are measuring, this is the pattern here you can look at for this individual, and depending on whether you are measuring at the trough. So if you are measuring at the trough, you are not accounting for the future rise of glucose levels. Let's say he is taking a meal and glucose level is going to rise. You're not taking into that into account, but the glucose level at the time you are measuring is lower. You're not giving any insulin, so that leads to a high level. And suppose you are measuring the glucose level after the individual has taken food, or his pattern is like that, and there is a peak. You are measuring at the peak, but if you leave it just like that, the glucose level would have come down. But you are giving insulin at this time and causing a further hypoglycemic event. So this is very important to remember. There's a lot of fluctuations, and recent studies have taken into account the glycemic variability also. That glycemic variability leads to increase in diabetic complications independent of the HbA1c levels. Two individuals having the same HbA1c level, but the glycemic variability is higher in one individual, that leads to increased complications. So knowing this, knowing all this, trying to change this in clinical practice, we feel like this, the figure what is it is showing. Many are unaware of the problem associated with insulin sliding scale, or unwilling to make changes whenever others have initiated treatment. So we have to look at the evidence. Not one study is showing benefit of using insulin sliding scale. So rather than the reactive approach, we have to use a proactive approach to glycemic management specifically in the inpatient scenario. So the proactive approach would be a basal bolus regimen, go into the history of the patient, look at what pattern is there, and look at what changes are happening after admission to the patient. Their food pattern is going to change, the environment is going to change. Take that into account and institute something called as a basal bolus. You give meal-based insulin and a basal insulin to cover the fasting hyperglycemia. So with this talk, I'm coming to the end of my talk. To summarize, India is changing. The prevalence of diabetes, other lifestyle-related diseases is increasing. So also the complications, gestational diabetes and its complications are going to increase. So it becomes very important to get ourselves equipped with the knowledge of different treatment modalities which are available in glycemic management. So preventive aspect is very important. So pre-conceptional counseling and screening plays a very big role. Diagnosis with DIPSI method, first step method, second step method, according to the scenario. So as our country moves from the generalized approach to more specific patient-centered approach, probably we'll be going to the one-step method or a two-step method. Choose insulin according to the scenario. Look at the glycemic status. Look at if the hyperglycemia is very high. Look at admitting the patient and bringing about a glycemic control earlier. Newer insulins definitely have a better treat to target profiles. In most of the large studies, they haven't shown differences compared to regular insulins with regards to the hard endpoints, either the fetal endpoints or the mother-related endpoints. Continuous glucose monitoring or the flash glucose monitoring is offers ease of use of measuring glucose levels, specifically in type 1 or type 2 diabetes mothers with hyperglycemia. So identifying hypoglycemia is very important when we are using insulins and treat them accordingly. We also have to teach the patients how to identify and treat hypoglycemia at home itself. So to the end, we should definitely avoid using the sliding scale, which is still in widespread usage in the clinical practice. With this, I hope I have added some value, some little bit of information to your knowledge. I again thank Dynamic ASB for giving me this opportunity, and I thank everyone for the patient hearing.
Thank you
very much, sir, for the talk. Now, madam, over to you for your expert inputs in this. I think there are going to be a lot of input. As a gynecologist, maybe we differ from, from what.
I think, Dr. Sandeep, you did a wonderful job. It was quite comprehensive knowledge sharing about insulins. And indeed, it was a pleasure to listen to you. There are some points which I picked up, and so therefore, I've noted it down for my own practice. Yes, one thing that is very important that will be a good adjunct to the insulin administration is self-monitoring of blood glucose, because these are days when every person has a smartphone. So if you can afford a smartphone, I feel you can always afford glucometer. And monitoring of blood glucose is extremely important, even for a person who's on a diet management. So that would go a long way. And especially for patients who are on insulin, self-monitoring of blood glucose will give us a good opportunity to manage the blood sugars, to identify situations when the sugars are high and sugars are low, etc. So that is one input from my side. And you manage to cover all aspects of insulin, including the storage and how it needs to be administered, etc., etc. Very well. But what our gynecologists would want to know probably would be how to start off giving it for a simple patient who has just got sugars more than, say, 140 when we diagnose CDM. And how do we start off giving insulin for this patient? What kind of insulin would we want to give? Would we want to give her regular insulin, or would we want to give her a mixed insulin like your mixed preparations? These are simple things that, see, not everybody will have the luxury of having a diabetologist like you, or even a physician for that matter. So if they are working at a center where they will need to manage at least the simple GDMs that they come across, where diet and exercise is not able to control the blood sugars, then probably they'll need to add insulin. How do they start off giving insulin in this kind of situation?
Very important. So this is a very important point, ma'am, where the caseload is very high and you are not able to give a very personalized approach. In those scenarios, look at the glucose levels. Ideally, patients who are sent to me, I would like to do a 1 week profile and see how the glucose profile is that. And there we will be able to identify let's say whether this lady specifically has a postprandial peaks and doesn't have a fasting hyperglycemia. So I'll be adding meal-based regular insulin for them. Let's say if the lady is having a only slight hyperglycemia, then still, let's say a fasting plasma glucose, even after a 1 week to 2 week of controlling your diet and exercise lifestyle changes, it is 100, as mentioned, 100 to 126. I'd like to still use a meal-based insulin and then see the response. If it is higher than that, then I would like to add a basal insulin. So if we are not able to do this monitoring at home, the easiest way would be to do a fasting and postprandial glucose level after a week or 2 weeks. If the fasting level is not that high, start off with a let's say meal-based insulin, approximately 4 units for each meal. But as we are moving towards a more personalized approach, I would want all women with gestational diabetes to measure the hyperglycemia levels and then report back to their doctors.
Yeah, that is the reason I said self-monitoring of blood glucose is extremely mandatory, and it forms an integral part of diabetes management. There was a question earlier. The first question that came across: in spite of strong meal-related peaks of physiological insulin, why to add in pH? And after delivery, how to curtail insulin? So this is, one must understand that there is a lot of insulin resistance that comes in pregnancy. Of course, with every meal, there is a rise in the insulin levels, but then there is not a proportionate rise in insulin level. And there is some amount of a requirement of more insulin, and that is why you get to see hypoglycemia. Right, Dr. Sandeep?
Yes,
Therefore, there is a need for more insulin than the physiological insulin. Then, yeah.
The question was, ma'am, why to add NPH? The question is, so when we look at insulin resistance usually we think of it as two-pronged. One is the peripheral insulin resistance in the peripheral tissues. Other is the hepatic insulin resistance. So in pregnancy, both things are accentuated. So what is the result of hepatic insulin resistance is that there is a glucose output which is happening in the late postprandial period, because there is glycogen breakdown in the liver. So if the glycogen breakdown is more, that will lead to fasting hyperglycemia. This will lead to the overall hyperglycemic status being deranged. So that's where the basal insulin comes into picture in the physiological. So that's, I mentioned the.
Yeah, you did. You
graph.
did mention. Yes. Yes. They did ask, why should we check? Is it necessary to investigate all pregnant women with GTT? All pregnant women. Should we be doing a GTT for all pregnant women? Basically, should we screen all women for gestational diabetes?
In an ideal case, definitely yes. But with our case burden, I think we have to identify. That's where I think, ma'am, the preconception.
No. I strongly feel that every single pregnant woman should undergo a GTT. Every single pregnant woman should undergo a GTT, because you will miss. See, GDM is not symptomatic situation like your diabetes mellitus outside of pregnancy, where they have polyuria, polydipsia, or loss of weight or whatever. A GDM woman has absolutely no symptoms. And unless you subject her to a GTT, you will not know if she has any abnormal glucose values. And India being such a kind of a population where our diabetes is increasing in a very geometric proportion, it is very important. If we have to take care of the future population, we need to check all our women for glucose tolerance during pregnancy. So there's no to, whatever the load is, if the government of India can do it at primary health centers, I think, it can be done everywhere.
In a personal private care, definitely we have to go ahead with the, and so also in the primary care health centers straight. And because the DIPSI is easier to follow compared to the other IAD-PSG guidelines. So definitely we can do that.
And then there is a role of sliding.
May I add to?
Yeah.
Hello.
Yeah.
May I add to? Whether Oswald sir is also there, he asked that question, whether it's GTT or GCT, because GTT, when we say glucose tolerance test, we talk of the 2 hour and 3 hour, 3 values at least. And GCT is we are doing a test to screen and diagnose GDM at the same time. Now GTT, I think at least we have stopped doing a long time ago. We are just doing a single level and 140, and we start treating the patient with, of course, monitoring and all those things. And we are actually, insulin for us is not the first line of action, because as madam said, there are lots of myths and lots of problems for making, your patient to accept that treatment. So we are still starting with metformin, and till now we have not had a case where we had to, shift from metformin to insulins. Luckily, of course, there are lots of patients who got very high levels. But GCT is what we are doing, and GTT, we take it as glucose tolerance test 3 levels.
If I may say, when we say glucose challenge test, that means we are challenging the body with a load of glucose. So whether you are doing an oral glucose tolerance test like that, fasting and 75 grams and 1 hour, 2 hour test, or whether you are doing a DIPSI test, they are both glucose challenge tests. Now, there are a lot of controversies, women saying that, or some doctors saying that, no, we want to do the IAD-PSG, we want to follow the fasting and 2 hours sugar values, 1 and 2 hour sugar values. And there are some who say, no, we want to do the DIPSI test. I say, do any test, but challenge the woman with glucose. Unless you challenge the body with glucose, you will not know whether the insulin in a body will meet up to the expectations, to the requirements for that matter. The glucose challenge test is whatever test that you follow. You're challenging the body with glucose. And that is how I meant when I say GCT. I don't now, I don't insist on people doing DIPSI test only or IAD-PSG test. There are some people who are saying, no, my patients can afford, they can come any number of times. And I would prefer to do the IAD-PSG. I said, go ahead and do. But the rest of the population needs to follow some test and some glucose challenge test. You can't be doing RBS and you can't be doing FBS during pregnancy and read off the values to say whether what GDM. So that is where I'm saying challenge the body with glucose.
Yes, ma'am.
Right? Anything?
Yes, yes, definitely. Sir, Sandeep sir has anything to add to that?
No, there is one question which related to.
Other thing is that when we do a glucose challenge test only according to the general physiology is that we only have postprandial hyperglycemia. There are a certain set of women who also have predominantly fasting hyperglycemia. So when we do a two-step test, one-step test, that is the IID-PSG, we identify the fasting hyperglycemia also. So those scenarios, if you don't want to miss, then definitely we have to go ahead with the IID-PSG.
And I would also insist that every woman, don't wait for 24 weeks. Please do a test in the very first trimester at the time of booking. That is very important. Don't wait for 24 weeks, 28 weeks, because I have noticed a woman comes to me for infertility. Her sugars are absolutely normal. She becomes pregnant. At 5.5, 6 weeks, I check the blood sugars again. I find that it has gone up. So this is a fairly common scenario. I don't know. I need to work on more data regarding this. So pregnancy somehow pushes a woman who's on the brink of becoming diabetic to become a diabetic, I feel. So that's it. There is a question on the role of sliding scale in intrapartum and postpartum management. Now, would you like to take that? Or during intrapartum, our idea is to make sure that the blood sugar values are less than 120. And this is the only situation during pregnancy where we would like to give intravenous insulin, because we want to make sure that the sugars are within that range. Ideally, what we start is take one dextrosaline, 5% dextrosaline, add 5 units of insulin to this, that is a regular insulin, and run it at the rate of 100 ml per hour. This we do only during the active phase of labor. So 500 ml of dextrosaline, add 5 units. So essentially, every 100 ml will be carrying 1 unit of insulin. Generally, the sugars get controlled with this. If required, we can modify the insulin dosage based on the blood glucose. Manpreet, are we done here?
Yes, ma'am, we are done. Just one more, just one point. You said that first trimester GCT is important. We've done a study of 1,000 patients in which we diagnosed 4% of our diabetic patients in the first trimester itself. And they were all GDM, they were not pre-gestational diabetes. So yes, that makes a lot of sense that now we started screening them. And actually, if they're negative in the first and second, we also screen them in the third trimester and vice versa. So if we are any more questions, I think there are no more questions also.
Probably there will be a term called early gestational diabetes also.
Now, I don't know how many of you would be interested. The recent concept is prevention of GDM by evaluating the glycemic status at 8 weeks of pregnancy and make sure that it is less than 110. You get a postprandial blood sugar at 8 weeks. If it is more than 110, you give her a proper diet counseling and maybe even give metformin. And by 12 weeks, by 10, 11 weeks, you make sure that the postprandial blood sugars are less than 110. This is propagated by Dr. Seshaya, and there are several studies going on in this. The basic concept is that the fetal pancreas starts producing insulin by 11, 12 weeks. So beta cell hyperplasia due to maternal hyperglycemia can happen as early as that. Now, once fetal beta cell hyperplasia happens, there is nothing that we can do by controlling the maternal sugars later on. So this is the concept. You know, in the prevention of GDM, there are papers we are trying to collect data from our own communities in India to see. There's one paper on HbA1c in early pregnancy and how it reflects those who develop GDM later. Are we done here?
Yes, ma'am. I think it's my honor and privilege to propose the vote of thanks. At the outset, I thank Dr. Lakol sir and Dr. Karunakar sir for supporting our webinars. I also thank a special thanks to Dr. Sandeep Dongam for giving us extensive talk on insulins and clearing many of our doubts which we had, and Again, special thanks to Dr. Sushila Rani ma'am for having added on to the expert comments of Dr. Sandeep sir. Thank you, ma'am. Thank you, sir. And my special thanks to all the delegates who have taken out a special time for this. Yes, it's okay. Thank you so much and good night, everyone. Thank you.
Dr. Sandeep, I particularly appreciated your PowerPoint presentation. It's lovely to watch. Thank you very much for the good presentation. And thank you, Manpreet, for moderating this session. Thank you.
Thank you.
Thank you, ma'am. Good night, everyone. Thank you, sir. Good night. We leave the, yeah.